my topic is much more exciting than probably what we are hearing routinely. Is what do we have beyond this antihyperglycemic and antihypertensive agents for diabetic kidney disease? My talk will be divided into three parts. So, are we following the guidelines for using the newer therapies to protect against DKD? What are the future therapeutic modalities? What are we are going to see other than what we are already using for diabetes? And the newer molecules which are there, are they useful, or probably are they useful in children and adolescents with diabetes? So this is where I'm going to discuss. So now all of us know the a lot of landmark trials regarding SGLT2 and GLP-1 has changed the outcomes and probably changed the working protocols in diabetes with time. As Dr. Talwar rightly said, the earlier protocol was to control sugars and good HbA1c levels, and that was probably enough for us to be happy that we are doing what we should do. Now the times have changed, where probably after studies, Credence, DAPA-CKD, EMPA-Kidney, these trials have focused more on the cardiovascular and kidney outcomes. And further, all the guidelines which are there, the ADA and ACC 2020-2022 have focused more on complication-based therapy for diabetes. So earlier, what used to be like just control of HbA1c now focuses more on the atherosclerotic cardiovascular risk, diabetic kidney disease, CKD, and probably the heart failure related stuff. So if you see all the guidelines, though, the guidelines will focus on starting this. So if we read the ADA ACC 2020 guidelines have specified that SGLT2 are indicated probably in patients with diabetes, with CKD, heart failure, and an established atherosclerotic risk factor. The GFR, which we are comfortable using these molecules, is somewhere between 30 to 60, or probably a urine albumin creatinine ratio more than 30. So it focuses on diabetic kidney disease patients which will have more term risks of heart failure or an atherosclerotic risk factor, and also focuses on slowing down the disease, where they are already focusing on urine albumin creatinine ratio, where they seeing early diabetic kidneys already set in for patients. So and if we see, even after probably last 2020 guidelines, still the use of these molecules, the GLP-1 RA and the SGLT2, is not yet frequent or rampant in all the patients probably who are into early diabetic kidney disease. Again, SGLT2 use in probably heart failure with reserved EF is recommended completely, and it is the guidelines have changed from the base four pillars. The SGLT2 becomes one of the four pillars of treatment of heart failure with reserved EF. So that is one more criteria. What are the barriers? So there are a lot of barriers even after having guidelines over last 2 to 3 years. There are multiple barriers of not using these molecules for the treatment of probably diabetic kidney disease or patients of diabetes with atherosclerotic risk factors. So what we see is, though the guideline recommends both the drugs, their use probably to reduce CKD and kidney risk in type 2 diabetes and CKD is much lesser. The SGLT2 and GLP-1 use in patients who will experience or have the most benefits, the use percentage is much lesser. So studies have shown that probably we'll need multidisciplinary collaborations across the care pathway, right from patient education to clinician education to probably more explanation of the drugs. And that is how we are going to probably take out the barrier and give maximum to the patient. Further, going to what are the probably newer molecules which we are seeing? What we already know is right from your sulfonylureas to metformin to this SGLT2 and GLP-1, the ACE ARBs. And of course, for further molecules, we have ERNI or probably heart failure related kidney disease. We have this ERNI molecules. Now we are focusing on molecular levels. So if we see what drives the diabetic kidney disease forward, one is the hemodynamic alteration. So hemodynamic alteration is taken care by your RAS and the SGLT2. The most important factor which is found is the hyperglycemia, which leads to metabolic dysfunction, which leads to mitochondrial dysfunction. So we'll need something to focus on the mitochondrial dysfunction. At present, what we are using is the SGLT2 and GLP-1, which takes care of some part of mitochondrial dysfunction in the patients. Second most important factor which drives the diabetic kidney disease is the inflammation and fibrosis, which takes care with TGF-beta 2. So whenever the disease sets in, slowly the inflammation and fibrosis will take care and will take the disease further. For taking care or mitigating the inflammation and fibrosis, we use the MRAs, the RAS, and the SGLT2. Now coming towards the mitochondrial probably dysfunction. So if we see in any case of diabetic kidney disease, there will be probably at the level of cells, there will be hypoxia, there will be a protein modification or a glycation asphylated glycated products which will start affecting the mitochondria, and there will be a increase in reactive oxygen species. This all will lead to mitochondrial dysfunction, and mitochondrial dysfunction will further lead to progression of diabetic kidney disease. So this is how we probably the target is now mitochondrial dysfunction. Second, we have the oxidative stress and the inflammation. So if we agree, hypoglycemia leads to a constant state of oxidative stress, and that leads to a constant state of meta-inflammation and metabolic dysfunction. So multiple molecules have been worked on for meta-inflammation. That is baricitinib, pentoxifylline, the non-steroidal MR antagonist, the endothelial A antagonist, the mineralocorticoid receptor antagonist, the TGF-beta, the perfenidone. So these are all multiple molecules which are into the trials for probably reducing the oxidative stress and inflammation and trying to slow down the diabetic kidney disease rather than what we're using already for diabetic kidney disease. We have targeted therapies towards the NAD plus augmentation. So the nicotinamide augmentation, which again is a major role, which causes glomerular dysfunction and albuminuria. So whenever there is a decrease in conversion of nicotinamide to NAD plus, there will be a significant glomerular dysfunction, and that will lead to albuminuria. So multiple studies have been done to probably take care of this NAD plus, and Na plus augmentation clinical trials have been studied. Multiple studies have been done, which are probably into the pipeline. The next in the row is the JAK-STAT pathway, the Janus kinase signaling transducer and activator transcription pathway, which again probably slows down the fibrosis. JAK2, we as all of us know, JAK is multiple probably in multiple diseases. So that is where studies have been done. The baricitinib is a molecule which is probably used, and in one of the studies they have probably studied 129 patients with a GFR of 45 and a urine albumin creatinine ratio of somewhere between 400 to 1600. And baricitinib was shown a 4 milligram use of baricitinib had significant reduction of urine albumin creatinine ratio by around 41% use at the end of 24 weeks. So that is significant reduction of albuminuria which we are seeing from the probably JAK-STAT inhibition pathway. It also reduced significant inflammatory markers in the study. So this is how, again, one more study which takes care of things. As I already discussed, the kidney fibrosis, which remains as an important part of the diabetic kidney disease progression. And TGF-beta, as all of us know, is the major molecule which takes care of this probably kidney fibrosis, which is taken care of. So multiple studies have been done to have the inhibiting signaling pathway of TGF-beta. And as all of us know, perfenidone is been the molecule which takes care of this. So it has been tried in both diabetic kidney disease type 1 and type 2. And perfenidone probably has been shown to reduce the inflammatory markers and reduce the fibrosis in these patients, which were studied. Multiple ongoing trials are going on. We have the pentoxifylline in diabetic kidney disease trial, the PTX-RX trial, a phase 3 trial of bardoxolone methyl in patients with diabetic kidney disease, the AYAME study, which is going on. We have the finrenone already in the market, which is there, finrenone in type 1 diabetes, the FINE1 trial, which is still going on. And we have the Mosaic trial, which is use of celocernib in the patient with diabetes. That is again study which is going on. So multiple biological mechanisms behind the mitochondrial dysfunction and oxidative stress are the attracted targetive molecules, which we are going to see in future use. Most important parameter for reducing or slowing down diabetic kidney disease is timely intervention. And combination of multiple therapies targeting different biochemical mechanisms to mitigate or slow down the diabetic kidney disease will be the key in future. And we still need multiple clinical and randomized trial to focus mitochondrial dysfunction and oxidative stress in type 1 diabetes, which is still lesser. Most of studies which are done are in type 2 diabetes. Coming to probably the last discussion point is where are we on these molecules in use of probably children and adolescents. So as all of us believe, obesity, dyslipidemia, hypertension, the scene of type 1 diabetes, and a part of vitamin D deficiency and the early fatty liver, which we see in a lot of adolescents these days. So this is probably been to be taken care of, as we don't in longer term, the this is going to progress much faster. So if we see, FDA has approved multiple molecules to treat pediatric type 2 diabetes, and which includes metformin, the liraglutide, the exenatide, the empagliflozin, metformin combination, and the semaglutide. So multiple molecules, right from SGLT2 to the uh, newer generation molecules which we are seeing, has been tried. Sonar trial was one which studied probably adults between 18 to 85, though the age group was wider, but it studied probably use of multiple molecules in pediatric patients as well. So to conclude, probably further studies to see for youth and diabetes will be needed, and on front of kidney specific endpoints will be needed to probably use. There will be a therapy probably in youth to see care of SGLT2 use wherever possible. SGLT2 along with MRA to reduce the risk of hyperkalemia. SGLT2 with endothelial reception antibody to see for fluid retention. And multiple combination drugs in future, as we discussed, to slow down the diabetic kidney disease progression, which we are seeing, rather than focusing only on HbA1c and sugar levels, which will not help us. So this is where I probably conclude. Any questions, we'll take it at the end.